everyone. Thanks for hosting us, Jessica, for the Global Health Symposium. Was there anything you wanted to do for housekeeping or introduction of the day before we got started on the Ethiopia team? See, Jessica, was there anything else you needed for housekeeping before I started talking about the Ethiopia team? All right, well, if not, good afternoon and welcome to our Global Health Symposium. We have several faculty working in the global health space who are going to give a little sampler about their work today. And I'm excited to launch our discussion time by talking about some of the things that the Ethiopia team is working on. And as we get started, I'd love for you to unmute, turn on your video, and share any thoughts or ideas. Have you ever encountered this experience where there's something that you know works well, but it isn't actually done in the real world? Have you ever had that experience happen to you? And if so, what was it like? You ever hit that roadblock where something you know is the best course of action isn't actually happening in the real world?
Looks like we have some shy participants today, John.
Perhaps so. I was hoping for like a dialogue group. I'd love to hear some ideas. Well, this isn't a revolutionary idea, but I'll just put it out there as food for thought. So my currently 9-year-old son, Solomon, at the time was about 3.5 years old when we had first moved back to the United States after living in Kenya. And he had a certain mental model of the world about how things should work well when you're trying to move into a new house and you're going to Home Depot to buy things to get ready. As we were in the checkout line, the scanner continued to have malfunctions. And so my 3.5-year-old child starts to have a dialogue with the scanner at Home Depot about what Solomon thinks the scanner gentleman needs to do to optimize his equipment so that it won't keep failing when it's scanning items. And so even in the 3.5-year-old world, there might be these times where something you know could be better isn't actually happening. And so that's what I'd like to take a few minutes and talk about today. When we think about newborn survival from a global perspective, we know that of all newborn deaths globally, 24% of them happen in India, 10% in Pakistan, 9% in Nigeria, 4% in the Democratic Republic of Congo, and 3% in Ethiopia. So when you look at the world as a whole, 50% of all newborn deaths are happening in just 5 countries that carry this highest burden. So we're going to talk about Ethiopia and what's happening in Ethiopia. So here's a map of Ethiopia. I work primarily in the Amhara region. I'm going to talk about our partnerships in the Amhara region. So if you look back to 2005 at the under 5 mortality trend in Ethiopia, it was 123 under 5 deaths per 1,000 live births in 2005. And that dramatically decreased over time, so that by the time you get to 2019, that's at 66. But if you compare that to what's happening in the newborn period, the first 28 days of life, that blue line is essentially flat. And so what happens is over time, when you look at what's the proportion of the ages of the children dying, early on, 2005, it was about 28% of the deaths were from the newborn period. And over time, that got increasingly high. So now we're upwards of 45% of all under 5 deaths are happening just in the newborn period. And of those deaths, the majority are happening from infections and complications of low birth weight. So as you think about newborn mortality, sepsis is a big driver. And as you think about under 5 mortality, the newborn period is the big driver of that. So part of what our team is working on are strategies to improve sepsis and low birth weight survival. So I want to talk about the partnerships. I want to focus our attention there as we have just a few moments together this morning. In your own work, you've probably seen kind of a standard approach to health or toward solving problems in clinical care or Home Depot scanners in my 3-year-old's situation. Some of the standard approaches that you might see to a problem, if we think of this cartoon of this individual on the bottom right having a problem or challenge, you know, he goes to the human resource department and they say, oh, I'm sorry, that's not our department's responsibility. If you go to the business side, the business solution side, oh, I don't know, go talk to someone else. Okay, well, maybe it's technology. Oh, not my problem, I can't help you. And we often see in the challenges that we face these type of siloed approaches. You know, let's find a clinical solution. Let's find a community solution. Let's find an antibiotic solution. And I want to ask, is there possibly a stronger approach that we could use in our work instead of treating very complex problems in silos? So with the Emory Ethiopia team, we're focused on finding globally informed solutions that are locally relevant. And we're trying to bridge that science and context divide for mother and infant survival. And so we're looking at both newborns and mothers. I'm going to focus this morning on newborn survival and talk about sepsis. Sepsis is in and of itself a complex problem. You might have sepsis or bloodstream infections happening for newborns at the community level or at facilities. So the difference in sepsis could be pretty stark between whether it's happening at the household or at the hospital. And so we've been doing work on sepsis to understand the social dynamics of health seeking for babies in their first 28 days of life, and looking at factors related to access, how accessible are the health facilities and the community volunteer networks to the infants. But we've also been looking at facilities and hospitals, looking at the standards of care, how newborns are treated across units in the facilities. How are low birth weight infants who are particularly vulnerable cared for? And then what about the water, sanitation, hygiene in the facilities? So this one simple problem of newborn sepsis, you can see it's got hospital sides, home sides. It's got the birth weight status of the newborn, social dynamics, and water access in hospitals, just to name a few. So as we think about sepsis, which is the big driver of death for all under 5s, and particularly in those less than 28 days of life, that's, again, not an issue in isolation. We have the issues about what access do you have to water, what's the birth weight of the infant when they're born, and then how can you access, measure, and track their temperature, keep their body weight, keep their bodies warm, and then also measure their body temperature to catch early signs of sepsis. So all of these factors, among many, many others, but these are some of the factors that are driving mortality for infants less than 28 days. So what if we could find a stronger approach, not just, you know, a one size fits all, you know, improve the water access at the facilities, improve the temperature monitoring. And so what we've done is we've brought together a team. We've taken the frontline health workers, the communities and families, technical experts, scientists, clinicians, and government officials, and we've blended these 3 different levels of partners and brought them together to address this wicked problem of newborn sepsis. We've worked to bring alignment across their power, privilege, authority, and perspective differences. And we found that by bringing the governments, the scientists, the clinicians, and the communities together in with our not-for-profit Emory Ethiopia, we're better able to harmonize the perspective of these partners. So I want to tell you about one work that this partnership did, and then some extensions. So when you think about low birth weight infants who are particularly vulnerable to sepsis and infection, globally, we've known for 30 years that KMC, which is skin-to-skin contact and exclusive breastfeeding, can dramatically reduce their mortality. But when you look globally at how often is this intervention actually used, it's much less than 5%. And so our team worked with those partners that we talked about to create a system for getting KMC into routine practice at facilities. We had program learning teams who would learn what was happening, understand the dynamics of giving the care, implementation support technical experts who'd help the mothers and the nurses and the clinicians to deliver KMC. And then we had outcome measurement teams on the top right who would measure the impact of this interdisciplinary work on the actual uptake of KMC. And what we had happen, so from a baseline of less than 5% of any type of KMC being given, and low birth weight infants being at extreme risk for mortality, what we had was that 88% of our infants who started KMC during this implementation trial actually survived. So we know from meta-analyses that KMC can reduce mortality about 40 to 50%. And what we found in these approximately 1,000 infants, that once they started, that they were, this was a very powerful intervention. And secondly, we had extremely high coverage. So at discharge from the hospital, 73% of our infants who started KMC sustained it at the point of discharge, versus less than 5% of any KMC at baseline. And further, as you see what happened with some of these infants, we did have about 413 of them that died before they could be stabilized to start KMC. And this is actually an area of future direction, which I'll talk about in a minute. Is like, how can we conquer this 413 that we lost? Approximately 30% of our preliminarily eligible infants. So this is sort of a high-level view, the 88% survival of all the infants who were eligible for KMC. And we also achieved a high quality indicator. So at baseline, there were no globally established definitions of how long you should sustain skin-to-skin contact for maximal effect. And what we found over the course of the study, if you follow the blue line on the top, in the 3rd iteration of our model, we were achieving 12 hours of continuous skin-to-skin contact and upwards of 15 by the time patients were released from the facility. So a high quality coverage. All of this work in our consortium resulted in a model for KMC implementation in government facilities to be used nationally. So we started with this wicked problem of low birth weight infants who aren't getting care and aren't surviving. And over the course of 3 years of partnership, we've had high quality, high coverage, high survival, and now a model to guide national implementation of KMC. So we suggest that this partnership approach of aligning partners across power and influence levels is a more powerful way to address newborn survival. And as I wrap up, as I know some other colleagues have exciting pieces to share too, I'd just like to also plant a food for thought about how partnerships often work. Many times in our work, we are successful, we get funding, and we have a latency period of building up our work, and then we're really able to discover great things, but then our funding ends, and some of that momentum is lost, and then we get some more funding, we have another latency period to get up and going, and we've had a foundation to build on, but we've lost all of this, all of these opportunities to more synergistically build. And so what another piece that our team is really focused on is trying to have multidisciplinary, multi-investigator work, solving real-world government priority problems so we can have more of a sustained profile of funding. So instead of this big drop-off, as we see as typically happens, we're trying to get multidisciplinary funding to sustain the partnership. And that's been going on for 12 years. And one of these opportunities we've had is support from the Global Financing Facility with $1.4 million to build on our existing work in the Amhara region as part of a consortium. And for time, I'll have to skip over all the details of the package, but it's focused on low birth weight infants and bringing our successes into a broader package over the next 3 years. We're also in the final stages of getting contract for $5.2 million with UNICEF to improve the continuum of care for vulnerable infants in Ethiopia. So our team is passionate about building and sustaining partnerships so that we don't have as much blips, ups and downs in the service delivery, and we build on the strengths of all of our partners together. So there's a lot more to talk about. So just a high level view of some of the pieces that we've been involved in. And thank you so much. I know that we'll probably have time for questions after everyone has an opportunity to share their work from across the globe.
Okay, can you guys see my screen? Actually, let me just. Okay, are you guys looking at my screen now? You can probably see it.
Yeah, we can see it, Sydney.
Okay, great.
It's in notes view. You might want to hit the sheet.
Yeah, I will. Okay, great. Thanks so much, Dr. Kramer. It's so exciting to hear about everything that's going on with the Ethiopia team. I'm Sydney Spangler. I'm an associate professor here at the school. And rather than describing a specific research project, what I'm going to talk about today is some work that seeks to strengthen research capacity in a particular setting, emphasizing different aspects of this project as examples of ways to decolonize global health research in low and middle income countries. And although, I think the term decolonize is still not particularly well defined, hopefully you'll understand what I'm getting at by the end of the presentation. So first, just a brief overview. Muhimbili National Hospital is the largest public hospital in Tanzania, generally known as a referral hospital, although it also provides a good amount of primary care. You can see some of the statistics here. It's located in Dar es Salaam, which until very recently was the capital city. Now Dodoma is the capital city of Tanzania. This hospital is indeed recognized, I don't know, maybe not across sub-Saharan Africa, but most definitely in East Africa for its model of emergency services. So the Emory Muhimbili Partnership for Health Administration Strengthening and Integration of Services, otherwise known as EMPhaSIS, is a 5+ year, I say plus because we do expect it to continue, It's a project that's working to build capacity in 3 key areas that are kind of in line with MNH's 2022 strategic goals in the area of leadership and business processes, quality improvement throughout the hospital, and research infrastructure and productivity. So the project leads on the Emory side include myself, Dr. Brittany Murray from the Department of Pediatrics at the School of Medicine, and Dr. Jason Hockenberry from the Department of Health Policy and Management at RSPH. So what we do is largely provide or link to technical assistance for all of the various activities in each of these kind of realms, and offer, whatever other kinds of supports are requested. And my specific role is to work with Dr. Frager Chiwanga, who is the director of MNH's Training, Research, and Consultancy Unit, to strengthen research capacity and quality improvement where these areas intersect. Unfortunately, Dr. Frager was not able to be with us today, but she does send her regards to the School of Nursing. So more specifically, Dr. Frager and I work to foster independence with respect to research productivity. So to assist Tanzanians to do their own research for the health and well-being of their own populations. And as you can see here, we've taken this overlapping stepwise approach to the effort, starting with research infrastructure, and then moving into health management information systems, data access and use, and then finally to research mentorship. So now I would just like to describe just briefly the specific activities included in each of the steps for the research area, highlighting some actions that seek to address power imbalances or promote power shifts in the way that research is conducted. So first off, when it came to research infrastructure, there were really no dedicated resources for pre-award support and post-award management. There were also insufficient overhead charges on external funding. So we decided that we needed to design and implement pre-award processes. And so we did that pretty much based on the school, our own school's Office of Nursing Research proposal initiation form and the actions that occur after that. So they have their own PIF now that looks very much like ours and provides very similar types of services. MNH also committed 2 employees from their finance department to track and manage awards, and we did a lot of training with them around what that looks like and how that needs to move forward. And I think, perhaps most crucially, we reviewed current practices related to overhead charges and created an institutional protocol with updated charges for different kinds of grants and funders. So for example, local versus regional or international grants, public funds versus private funds. And putting this protocol in place was really important because it meant that MNH would no longer be taken advantage of through really what was previously highly inconsistent or non-existent, in some cases, overhead charges, where the hospital wasn't really reaping any of the financial benefit from all the research occurring there. It's a huge hospital, lots and lots of research, lots of international investigators, but they were assuming most of the risk. So then moving on to data systems, or as we sometimes call them, health management information systems. What often happens here is that external researchers enter hospitals and initiate electronic data collection for a particular study. But when the study is over, and the same thing happens in community settings. The study's over, as Dr. Kramer was talking about, the data collection stops and the data go away. And then you kind of have this lag. So in the view of MNH as the institution, here again, the institution, the staff were unable to really benefit from research that was occurring there. And in this case, high quality data for the purposes of future research, ongoing reporting requirements, and quality improvement initiatives, AKA data for decision making. You can't do quality improvement without data. So what we did was, in a couple of specific units, we designed and implemented platforms for collection of key clinical and process indicators that were fully integrated into staff workflow, including training on iPad and REDCap use. So now any MNH unit that is implementing its own HMIS platform, essentially owns and manages the data for its own purposes and benefit. It doesn't mean that research can't still happen, but questions can be added to the platforms that exist. There's ways that external research, and I'll get to that in the next section, but this was considered an essential aspect that was missing in the hospital. We started by establishing these platforms in the maternity block and the newborn wards, which then expanded kind of spontaneously as people started kind of getting the idea and getting excited about it, to critical care and to surgical units, to renal services, to breast cancer services. There's still a ways to go. This is definitely a work in progress, but it's so far working pretty well. And then when we think about related to this previous problem, I think separate but related, studies would happen and manuscripts would be produced often. In fact, this just happened about 2 months ago, again, with little to no MNH staff involvement or authorship, which not only presents an ethical problem, especially when the researchers are not even Tanzanian, but also meant quite a lost opportunity for research training and experience. So we developed an enforceable protocol for all researchers that seek to conduct data collection or use any existing source of data for research purposes. And existing sources here include the newly implemented HMIS that I just described, as well as any patient records, written records. They have some electronic records, not a lot, any administrative data, etc. So this protocol specifies that no research can be conducted at MNH unless at least one staff member is designated as PI, co-PI, or co-I. They cannot just be a project manager or a staff person kind of helping to implement. It includes standard data use agreement for external researchers, and the data use agreement specifies how and under what circumstances external researchers can collect data, store data, publish data, etc. And then of course it does a lot of other things as well. But finally, the document does reference the NIMRI, the national IRB approval, as well as the local MNH approval process. And then finally, it quickly became apparent that in order to improve its reputation as a premier research institution, which really is the goal, and sustain independent productivity, MNH needed to build more capacity among its junior investigators who will likely be working there well into the future. So what we sought to do and what we're doing currently is training a cohort of 5 mentees in research skills so that they're well prepared to effectively partner with more experienced investigators on externally funded research. So you can see what each of the mentee receives: basic refresher training support for 2 years from both local MNH senior mentors as well as Emory mentors, and funds for a small study. We have around 10,000 each right now. We may be able to expand that. So the primary outcome goal is a first authored manuscript by the mentee submitted for scholarly publication in a good journal. Mentees will also be supported to present an abstract in an international or regional academic or professional conference. If this pilot is successful, we do expect to continue with future cohorts and or partner with MUHAS, which is, it's a long story, but it's the now kind of independent academic arm of MNH for more training. And then we want to hopefully initiate sustainable research relationships between MNH and Emory scholars. So just to give you an idea, the current cohort of mentees includes 3 nurses and 2 physicians, and you can see what the projects are. We've got a project that's seeking to determine incidence of surgical site infection at C-section and contributing wash factors. We have another study that will be examining, we think it's getting refined, the relationship between estimated blood loss assessment, adverse maternal outcomes. You would assume that had already been done, but really it hasn't. It's a huge gap in the maternal health literature. Another study will be evaluating an intervention to prevent newborn hypothermia. We have a study that will look at will seek to characterize patterns in household burn injuries from liquefied petroleum gas. And then finally, there's a study that will seek to understand implementation gaps in diabetes care. And I should say, I'm really proud that 3 of our mentees are nurses. And I also just want to say that Emory mentors include Dr. Lisa Thompson, who will be presenting in a moment, Dr. John Kramer, who just spoke, as well as myself here at the School of Nursing, and then also Drs. Mo Ali, Joanne McGriff, Renuka Kapoor at Rollins, and Dr. Deepa Ranganathan at the School of Medicine. So just to conclude, I think, above all, and in keeping with this ethic of nothing about us without us, the enduring goal here is really to foster a mutually committed, sustainable, and authentic partnership that works to better health services in the public sector, specifically for all Tanzanians. And for those of you guys who have an interest in this concept of decolonizing global health, I'm working with a group at EGHI right now to, kind of produce a speaker series. The first one you can see, it will be November 10th. So I just wanted to put that out there, and I'll be sure to send this to the listserv. And that's it for me. I think we have next, Dr. Morland.
Hello, everyone. I'm Patricia Morland. I'm from assistant professor at the School of Nursing. And also on the call is Etienne Nusurko. He is from Rwanda, and he is the PI on the study that I'm going to talk about. So this is a study that was done in Rwanda. The title is Association Between Micronutrients and Maternal Leukocyte Telomere Length in Early Pregnancy in Rwanda. And just to give you a little background, telomeres are repetitive DNA sequences that are protective caps at the end of chromosome. They shorten with every cellular division, and they're an indication of cellular aging process. Shorter telomere length has been associated with multiple chronic illnesses, including cancer, diabetes, and cardiovascular diseases. We know that micronutrient deficiency and inadequate diet attribute to shorter leukocyte telomere length. We also know that during pregnancy, deficiencies of micronutrients and poor dietary intake can affect fetal telomere length and consequently have an adverse effect on the newborn child and actually throughout the child's lifespan. So maternal systemic inflammation during pregnancy has also been associated with reduced infant telomere length. And again, it can affect the fetus. So in sub-Saharan Africa, malnutrition of pregnant, lactating, and children while childbearing ages is very common. And in Rwanda, there are high rates of anemia in these women, as high as 19 and sometimes 30%. Also in sub-Saharan Africa, systemic inflammation, sexually transmitted diseases, or genitourinary infections are common. So the purpose of our study was to look at the association between nutrition and infectious disease and leukocyte telomere length during early pregnancy in women in Rwanda. And to our knowledge, it's the first study to be conducted in sub-Saharan Africa that looks at this relationship in pregnant women during the first trimester. So this study is part of a larger prospective longitudinal cohort study that was conducted between September and October 2017. And the initial study looked at the impact of maternal nutrition and infection on preterm birth. In the initial study, there were 420 pregnant women. They were recruited from 10 health centers in Gasabo district, Rwanda. And of the 420 women, we included 300 in the telomere sub-study. So we recruited pregnant women 18 to 45 years of age at 9 to 15 weeks gestation who had tested negative for HIV and syphilis and had a singleton pregnancy. We collected a lot of data. We looked at demographics. We looked at obstetrical history, pregnancy outcomes. We looked at gender-based violence and alcohol use. Then we measured BMI and mid-upper arm circumference that looks at malnutrition. We did a dietary history. We drew lab work for hemoglobin, soluble transferrin receptors that looks at iron deficiency, ferritin that looks at iron, and the retinol binding protein that looks at vitamin A. We also looked at markers of acute and chronic inflammation, CRP and AGP. We collected urine for urinary tract infections, and we did sexual transmitted infections. We looked at chlamydia, trichomonas, and candida. So the results of our study, the mean age was about 28 and gestational age was about 13 weeks. The mean leukocyte telomere length was 1.16. As far as nutrition, the BMI of most participants were within normal range. We had about 3.8 that were underweight and 12.4 that were obese. But a large amount of anemia, 33% of the women were anemic. As far as infection, inflammation, about 26, a quarter had acute inflammation. We saw that on elevated CRP, and 7.4 had chronic. We saw that on elevated AGP levels, and 36%, high rate, had sexually transmitted diseases. When we looked at these, though, we found no association between the biomarkers for inflammation, infection, including sexually transmitted infections, and the leukocyte telomere length. What we found for the independent predictors of longer telomere length was younger age, which is consistent across everyone. We found that no school versus primary school was an indicator of longer telomere length. And then we looked at the different levels related to iron. We looked at the lower levels of soluble transferrin receptors and lower levels of ferritin and lower levels of this retinol binding protein were indicators, predictors of longer telomere length. And that is different compared to different studies in Europe and America. And I'm going to talk about a couple of those. We did want to note that self-reported gender-based violence did trend toward significance with shorter telomere length. So what we found was that the leukocyte telomere length was a marker of biological aging in Rwandan women, which is consistent across most European and US populations also. We did find an association between body iron stores as measured by lower levels of the soluble transferrin receptors, ferritin levels, and longer telomere length. Now, this finding is consistent with a nationally represented study among US adults where higher ferritin levels were associated with shortened telomere length. Again, our study was in pregnant women. In Africa, this was a study in US adults, but those two were consistent. But in contrast, we found that another study that was done, I think it was in the US, they found that iron consumption was associated with longer telomere length. So we have very limited studies that have actually looked at this related to telomere length, and none have looked at it in sub-Saharan Africa among pregnant women. So why this is important is if you look at the context of this study and the environmental factors related to it. Because in East Africa and many countries in Africa, malaria infection is very common. And studies have found that lower iron levels have been associated with reduced susceptibility to malaria in pregnant women. So these lower iron levels may actually be protective or indirect health benefit in these areas of malaria. So the telomere length and associating with women or even with people in US and Europe may be very different than those in Africa or in areas where malaria is endemic. So what we ended up with is we just said we need to do additional studies to look at more diverse population groups. We need to definitely look at pregnant women and their nutritional health and telomere length to expand our knowledge on why this is an indicator. And Etienne, do you have anything to add? Oh, excuse me. This study has been published in BMC Pregnancy and Childbirth. We're just waiting for it to be released, but it has been accepted if you want to look that up. Etienne, did you have anything to add?
No, thank you. It's fine. The presentation was fantastic. Nothing to add.
Thank you. Etienne's my biggest supporter. I think we're going to do questions at the end, so I'll go ahead and I'll stop sharing and let Lisa. Oh, shoot. Sorry.
There we go. Oh, that was so interesting, Pat, and especially to see on the publication with Etienne, some of my colleagues from UCSF. So that must have been funded through the Preterm Birth Initiative.
Yes, it was funded through the.
Yeah, okay, that was really interesting. I'm like, there's Julien and Nicole. So I'm going to kind of switch to a different, this is so interesting to listen to everybody else and talk about something completely different, but perhaps we can find some commonalities. And this is research that I've been doing with the pilot funding from the Emory Global Health Institute. And the question is, what is the pollution burden from plastic waste and what can one community do? Community engagement with an indigenous community in rural Guatemala. And I've listed here the people that were instrumental to this study. Whoops, so background. Ambient, which we call outdoor air pollution, and household, which we refer to as indoor air pollution, is the #1 environmental risk factor for ill health globally. Something we don't think about, but when you put the two together, this environmental risk factor contributes to almost 7 million global premature deaths in 2019. And so I've illustrated on the right what we're talking about when we talk about household air pollution. This is typically solid fuel cooking over stoves that don't have chimneys, filling the kitchen or the household with smoke. And then on the bottom, we have an illustration of ambient air pollution. Most of the deaths from air pollution occur in low and middle income countries where there are maybe not resources to provide clean cooking, clean vehicles, or sanitation. And the lack of environmental policies or perhaps weak enforcement of existing policies is a problem. And that mainly comes from governments that have few resources and a lot of interest, competing interests. And so that is not a fault of any government. It's just that the prioritization may not be on clean air and household cooking. But one thing that people have not looked at, there's been many, many studies. I spent the past 20 years looking at household air pollution from cooking. People have not been looking at household waste burning, specifically plastic waste. So I just put this up here. The Lancet just came out with their global burden of disease study last week. And what it shows that in 1990, household air pollution was the 4th leading risk factor for disability adjusted life years. And it's moved down to the 10th leading risk factor through a lot of clean stove initiatives, but it still represents almost 4% of global disability adjusted life years. So it's still a significant burden. So many of you know I've been involved for the past 5 years on the HAPPEN trial. This is an 18-month randomized controlled field trial of reduced household air pollution on health benefits. And what we've done is we've enrolled 3,200 households in 4 countries, and we provided them with an LPG stove and free fuel, as much fuel as they wanted, to half of the households. And this was looking at not only just the delivery of a gas stove, but a behavioral intervention to encourage stove use. So you can see here on the right, this is the Guatemalan LPG stove. We chose stoves and spent a year of formative research to figure out what would be the optimal stove. And the pots that we give to the households were what households wanted to cook with. And then you can see a little calendar where we reinforced our behavioral messages. Our primary outcomes are low birth weight, infant stunting at 12 months, and incidence of infant severe pneumonia. I'm a co-investigator for the study and one of the leads for Guatemala. So what I've done over the past 20 years that I've worked in this area is I've seen people burning plastic in their fires. And in fact, the data from the national surveys in Guatemala has said that 71% of rural households burn waste. They burn their waste as the primary means of disposal. And plastic waste that isn't burned enters into the oceans at a rate of about a ½ pound per person per day globally. So I think we've heard a lot about plastic floating in the oceans, but a lot of people have, and there is very little literature on plastic burned in household fires. And here you can see Crocs, a cola bottle, and this is a chimney stove. You can see Tupperware and plastic bags. And this is the urban dump and fires in the urban dump being set regularly to burn all of the plastic. So the pilot aims of my study were to use qualitative methods to explore perceptions of solid waste, especially plastic trash in one rural community, and actions that could be taken to mitigate this burden. And we did focus this in Happen communities. We also wanted to estimate the air pollutant emissions from plastic incineration in 20 rural non-Happen households in one community. And the third aim was actually involving 60 adolescent girls in the Happen trial. And we wanted to measure their particulate matter and urinary biomarker exposures to plasticizers in burning plastic. And these were in households that use gas fires and the households that use the wood stoves. I'm only going to talk about the first two aims today. So the first aim was conducted between February 19th and February 20th. We used participatory action methodology. In the middle of this photo is the Guatemalan medical anthropologist who's worked with me for 15 years and is a very good friend of mine. She's a real community mobilizer and got this 70 women from one community to participate in what she calls working groups to develop strategies to participate in an 8-week period to develop strategies to reduce plastic. So what the working groups came up with, these women stated that they used to compost, but now they just dump their organic waste in with the inorganic waste and burn it all. They wanted to compost. Some of them women were quite young and had forgotten the old ways. They wanted to learn how to make organic soap because they were washing their clothes in the river and using plastic and these little plastic sachets that you can buy that are cheap, and then they were dumping them or burning them. They wanted to see if they could trap plastic in the river using a boom. That didn't work. We tried that out with local ministry environment officials. They wanted to pick up trash in their neighborhood. They wanted to start a recycling program, and they started to use non-plastic food containers. So they actually started carrying food plates and cups with them in their purses wherever they went, so they wouldn't use plastic or styrofoam. So I want to talk about the community recyclers because that was one of the most exciting things that women came up with. They wanted to start to collect their goods from the neighbors that they could then sell these materials to a central recycler. So we had meetings with the recyclers to talk about how to recycle. 11 of them were trained to understand the different materials, the cost of the materials, and how to sort them out. Signs were hung in stores that talked about how community households could bring the recycling materials to these women. And then in the end, the central recycler came to pick up the materials that women had collected in their village. So for aim 2, we wanted to estimate the air pollutant emissions from plastic incineration. And what we did is we asked 50 women to collect all the plastic they would have burned in their trash fires over a period of 4 weeks. And we administered a survey about household characteristics. We sorted the plastic trash, and the goal was really to quantify emissions of 78 air pollutants, including greenhouse gases. And so the results basically, 88 of 50 households reported that they burned trash, including plastic. in indoor and outdoor fires. The amount of plastic that we collected was about 2.5 pounds a week. And we estimated that based on the plastic waste we collected, that these rural households burn on average around 15 pounds of plastic per person per year. And a student in Emory College who works with Ari Saikawa estimated the emissions. There's the Guatemala World Bank data and the rural data, and this is very, very preliminary. You can see our estimates for carbon dioxide are, thousands of times higher than the estimate for carbon dioxide for the Guatemalan country based on World Bank data. So all the estimates are much, much higher. And so we're, this is very preliminary, it's a pilot study, but we think that there's an underestimate of the amount of trash burned in homes and outside of homes, but probably this is an overestimation. So we're working on these data. So in conclusion, our preliminary results showed that Jalapa, the area where we worked, the plastic burning could result in between 3% of CO2 emissions and 1% of PM 2.5 emissions for Guatemala. In other words, we're about 1/100th to 3/100ths of the plastic emissions and the contribution of that to CO2 and particulate matter 2.5. We're in the process of looking at AIM-3 data. That's a doctoral student who'll be looking at biomarkers of exposure to plasticizers. The 11 recyclers still continue to work in the community with local recycling centers. That was one of our successes. They haven't yet been able to generate a whole lot of income from it, but they have collected a lot of recyclable trash, not just plastic, but also computer parts, cell phones, broken bicycles, broken strollers, copper, things that they can sell to the recycling center in Jalapa. And the good news is that we did submit an R01, and this is actually to expand this model to 10 intervention villages and compare them to 10 control villages. We'll be using community-based participatory research methodology to help each village design their intervention that they want to embark upon related to plastic trash. And we're using an implementation science approach to evaluate the uptake and sustainability of these strategies to reduce, recycle, and repurpose plastic. We submitted the R01 in July. We just got our score this week. It's 10th percentile, which is the pay line. So I'm like very optimistic that we'll get it, but given all the uncertainties around funding, transitions and all that kind of stuff, who knows, but everybody light a candle, please, for this project, because I'd like to see it roll out. And I want to acknowledge all of our local partners that help with the collection of the exposure data, the laboratory data, the community members, which are just incredibly enthusiastic. Our Guatemalan graphics designer who designed the posters outlining recycling, and the Emory Global Health Institute for the seed funding. Thank you. Now I think we have about 6 minutes for questions. And I look forward to questions. I see that we have a few students that are still on, or anybody else that wants to ask questions. I wanted to ask Sydney, I think that was really a great presentation on getting building up the resources in a university so that they are part of the research agenda. And I was, one of the problems that we have is like this low costs that are given to partners in global settings. So, at Emory, we get something like 50% indirect costs, but NIH caps local institutions at something like 13%. They can never get more than that. So what do we do when we're constrained by funding agencies that don't give the same benefit to those institutions globally?
I mean, I think one of the first things to do is to set those institutions, whether it's a hospital or a university, up to be the prime on the grant, right? Like, I mean, that takes time and it's a lot of work and effort, but as opposed to being like in a subcontract where the prime is a US based or a Swedish based or what have you institution, like having those institutions receive the funding lives there. They ensuring that they can manage the funding, and then like the partner institutions become the sub. So, I mean, I know that's ambitious in some ways, but I feel like moving in that direction would be kind of the ideal thing to do. I mean, in the meantime, you can look for grants that, of course, we want overhead here too, but you can look for grants that are more generous in terms of the way that they will provide overhead and funding to partner institutions that are not in US based. So I think that, you know, kind of being cognizant of what that looks like, even though we all want NIH grants, there's something about that kind of sets up an inequity when we're talking about global health.
Yeah, and I know that John's had that situation, and I've had that situation where the prime is in another country, and then you become the perhaps consultant to the prime, so that you have to set it up so the money flows from there to here. And that is something that I don't think a lot of institutions in the US even know how to deal with. I mean, broadly speaking. And I've dealt with that at another institution and how challenging it was to try to create an infrastructure so that the money would come back to me as a consultant, which, you know, yeah, so it is a challenge. It's a big challenge. If money should go directly to the countries that are doing the work, that's just the way it should be. But our institutions have to support that happening too.
Well, Lisa and Sydney, maybe we could make a little consortium, because I actually am advocating for this at the university level at Emory, because the university system disincentivizes is too light of a word, that setup. And it's even put awards at risk for not being funded when the prime funding goes to a non-US institution, which is incredibly unethical. But we could, let's advocate together.
I think we're on that. We're on the same page on that. Yeah. Because it is quite an honor, right, to be a part of these huge countrywide grants that are, you know, but takes a lot. Any other questions from anybody? If not, we've only got 2 minutes left, and so we could end early, or people could pose questions, or.
Well, we have a break. I want to say really quickly that the pictures in my presentation were actually pictures of the team. They weren't just random pictures of people that I found. So I forgot to mention that, but they were pictures of the team that were here in the School of Nursing working at Emory, as well as at an Atlanta United game. And so, sorry guys, I just wanted to mention that.
Yeah. And I took all the pictures in my presentation. Yeah, I did that. That's except for the ambient air pollution one, that was stock photo. I didn't have to breathe that air somewhere to take that picture. Well, thank you all very much for listening to our talk, and we will see you all around campus hopefully soon. And for a couple of my students, I'll see you on Friday in our class. So thanks very much.
Thanks, everyone.
Thanks. Bye.